Hi, this is the second part of this topic that is called mild asthma. First of all, with this sequentially of this exposition, I have to first introduce by a video.
Children with mild intermittent asthma are children who, if they are not treated with any medication whatsoever, with any medicines, have symptoms like difficulty breathing, chest tightness, coughing, or wheezing no more than 2 times per week. In between those episodes, they're totally fine. They don't have any symptoms whatsoever. And when they do have episodes, they're brief, lasting hours or at most days. And finally, children with mild intermittent asthma have nighttime symptoms that occur no more than 2 times a month. For any child with asthma, our goal is to make them act like they have mild intermittent asthma. It's the mildest, best controlled form of asthma there is.
Well, the causes of this disease is a combination of complex and incomplete understood environmental and genetic interactions. These factors influence both its severity and its responsiveness to treatment. It is believed that the recent increased rates of asthma are due to changing epigenetics, that is, the heritable factors other than those related to the DNA sequence, and a changing living environment. Other causes are the most common, that are the environmental, genetic, medical conditions, and the last that is common, the exacerbation.
I'd like to take a moment to show you what a child's airways look like, what their lungs look like with asthma when it's controlled and when it's not controlled. You can see here that air enters through your child's nose or through their mouth, and it comes down through their windpipe to their lungs, shown here. And as it reaches into the lungs, it becomes smaller and smaller into what we call bronchi. Now, this picture shows a very detailed drawing of how air enters into the actual lungs. And from the bronchi, which we just saw, it goes to very, very small bronchi, what we actually call bronchioles. We have a close-up picture of what a bronchioli looks like. We're looking into a bronchiole, and you can see this is an airway in a child that has well-controlled asthma, someone who's actually on controller medications. This is what a normal, healthy bronchioli looks like. And you can see that there's muscle around here and absolutely nothing blocking the opening where air actually goes in. But over here, you see a picture of what an airway looks like in the child with poorly controlled asthma. You can see that the muscle around here is really very, very swollen, so that the opening is much smaller. And you can also see that there's a lot of mucus collecting in that airway. So what's left for air to pass is a very, very small opening, and that's what makes it difficult for children to breathe. The way we turn airways like this into airways like this is through the use of controller medications. But controller medications only work when they're taken every single day. So the best way to ensure that your child's airways look like this and not like this is to take your controller medication regularly.
Finally, we can include the diagnosis. The diagnosis, that there is currently no precise test, with the diagnosis typically based on the pattern of symptoms and response to therapy over time. A diagnosis of asthma should be suspected if there is a history of recurrent wheezing, coughing, or difficulty breathing, and these symptoms occur or worsen due to exercise, viral infections, allergens, and air pollution. The spirometry is recommended to aid in diagnosis and management. It is a single best test of asthma. If the FEV1 that I called before this measured by this technique improve more than 12% following administrations of a bronchodilator, such as salbutamol, that is supportive of the diagnosis. It, however, may be normal in those with a history of mild asthma not currently acting up, as caffeine is a bronchodilator in people with asthma. The use of caffeine before a lung function test may interfere with their results. Well, this is the technique of the spirometry. Here, the doctor is indicating the patient that this is a usually technique that you have to blow up the air in this instrumental medical that is called a spirometer. Now she is explaining how to blow the air with her mouth. She have to take all the air and then she have to blow. She has to close her nose because there is a little bit of percent of air that is going out the body by the nose, and all the air have to go out by the mouth. Thank you.